Hi everyone, and welcome back for part 2 of this presentation. So in this part of the presentation we are going to do a bit of a deep dive into the literature to understand what it tells us about how to measure the nurse-patient relationship. So a large part of our work here at Flinders University and the Caring Futures Institute as well is understanding how the nurse-patient relationship, and indeed all caregiving relationships, can be measured for the purpose of practice, education and research. So I'm going to talk through some of the work that we have been doing in this space to give you a bit of an idea of the current evidence base. So when we began this work about 5 years ago and we started scoping the literature, we could see that there existed a number of different instruments designed to measure the nurse-patient relationship, or at least aspects of it. But what was less clear was, first of all, the scope of these instruments. So what were they actually measuring? What constructs or what concepts? How were they developed? And could they be used across multiple care contexts or for different patient groups? And second, it was unclear whether these instruments were actually of sufficient quality and robust enough to actually warrant their use. And this missing information is vital for informing nursing documentation because it tells us what to document, when and how. So I'm going to talk through 2 studies that were really designed to tackle some of these unknowns. So the first was a scoping review of instruments measuring behavioural aspects of the nurse-patient relationship, and the second was an evaluation of the quality of those instruments. So in 2018, colleagues and I conducted a scoping review that aimed to identify and describe instruments that were designed to measure the actual behaviours that nurses employ to develop and maintain relationships with their patients. So in this review, we identified 127 different studies and 35 different instruments. And what we found was that the literature was characterised by substantial variability and inconsistency. And some of that was because the instruments went through inevitable refinement over time, but it was also because new instruments just seemed to be developed and they duplicated existing work. And there was also a lot of inconsistent use of instruments across studies as well. So I'll explore these findings in a bit more detail so we can get a sense of what they really mean. So what we found was that most instruments were used in, or they were designed specifically for, acute care, and just under half of the instruments were designed for use in only one context, one care context, and only 9 of the instruments had been used in multiple care contexts. Some instruments were used very frequently, whereas a lot of the instruments were used in only one paper, meaning often an instrument was developed, say as part of a PhD, and then it was never used again. Most of the instruments were developed specifically for nursing contexts, but there were some that were developed in other contexts, such as medicine and psychiatry, and then they were adapted for nursing. Importantly, less than half of the instruments had some form of patient or nurse involvement in their development or their refinement. And often that involvement was very minimal. So nurses and patients were simply asked to assess the comprehensibility of items. And the remaining instruments then were developed by researchers only, or potentially in combination with experts, but that was often not well defined. And less than half of the instruments could actually be completed by both patients and nurses, meaning the instruments weren't actually able to capture both perspectives. And finally, just over half of the instruments had more than one variation. So we defined a variation as occurring when an instrument was refined or it was modified in some way such that it had a different number of items, a different language, different subscales, perhaps a different scoring modality. And what we found was that some instruments had many variations. So one instrument, for instance, had 19 different variations that we could identify. So what does this all mean? So the large number of studies and of instruments that we were able to identify, it arguably demonstrates that the nurse-patient relationship and measuring this relationship is a key area of interest. But unfortunately, the sheer volume of instruments creates several challenges in choosing amongst the instruments available. And the volume and the variability that we identified raises two key questions that we need to address. The first is, why are there so many instruments and so many different variations of the same instrument? And secondly, but incredibly importantly, how does that volume and that variability impact clinical practice, education, and research? So the first key question is, why are there so many instruments and so many variations of the same instrument? So several factors seem to be at play here. First is that this demonstrates the inevitable progression of a body of work over time. So when we looked at the instruments chronologically, for instance, we could see that some had been refined over time, some had short forms that were created to make them easier to administer, particularly in a busy clinical environment as well. And some instruments had been translated into multiple languages to increase their usability. So in some instances, and for some instruments at least, having multiple variations actually reflected their strong utility and applicability across contexts. But in contrast to that, the volume and variability also seem to demonstrate a tendency for clinicians, educators, researchers to continually create new instruments rather than using the large body of work that already exists. And that seemed to lead to some duplication. So for instance, 26 instruments, or 26 of the instruments we identified were used in acute care, and of those 20 were in English. So it's safe to say that there exist at least 20 different instruments designed to measure the same concept, the relationship, in the same context, acute care, and in the same language, English. So to further explore the potential duplication across instruments and within the literature, we actually attempted to synthesize the items and the subscales, so the content of each of the instruments. But what we found was that many items and a lot of the subscales of the instruments were too ambiguous and vague and open to interpretation to really be synthesized in a meaningful way. So some items were really rich in description, whereas other items and subscales lacked a lot of detail. So for instance, some talked about loving kindness and others simply mentioned congruence. And you can probably also imagine how difficult it would be to translate some of those concepts into different languages as well. So that made it very difficult for us to actually determine whether and how each instrument overlapped in terms of its content. And importantly, that sort of ambiguity in terms of language and concepts and ideas, it highlights a third issue that seems to be contributing to this substantial volume in the literature. And this issue is that despite its recognised importance, the nurse-patient relationship seems to be poorly conceptualised and circumscribed. So for instance, the instruments that we reviewed were not based on any one consistent theory or framework. There were multiple theories and frameworks at play. The instruments had various sort of aims and scopes, measuring the relationship as a whole or potentially aspects of it, such as dignity, compassion, respect, and so on. Most were developed for nursing, but there were definitely some that were adapted from other disciplines. Some instruments were nursing specific, meaning they measured nursing only, whereas others also measured nursing in addition to other aspects of care, like the physician-patient relationship, for instance. Some of the instruments only measured nurse behaviours, whereas some also measured attitudes and emotions in relation to the relationship. So there doesn't appear to be a strong conceptual consistency and clarity around what constitutes the nurse-patient relationship and its key components, and not necessarily a lot of consistency around how those should be measured. And a final issue contributing to this volume and variability that we saw in the literature was the inconsistent use of instruments across studies. So often studies used the same instrument but with a different number of items, and they provided no explanation as to why the item numbers differed. Some studies didn't use an instrument in its entirety, instead cherry-picking certain items and administering those only. And many of the studies as well lacked a lot of important detail about the instrument that was actually used, so it made it very difficult to ascertain which version or variation was actually being employed. So this brings me to the second issue that I want to discuss, which is what is the impact of this volume and variability? Arguably, one advantage is that there exist instruments for different contexts and different languages and different patient groups, meaning we can assess and compare the relationship in the many varied settings and contexts in which it occurs. But there are two key disadvantages, and the first is that the large number of instruments available means it's very difficult for clinicians, managers, educators and researchers and so on to know which instrument to use, particularly in acute care where so many different instruments exist. And secondly, the structural variation in the instruments, so the difference in terms of the number of items or scales or subscales for the same instrument, and the fact that instruments were used so inconsistently means it's very difficult to actually aggregate results from across studies, even if they've used the same instrument. And the inability to make these comparisons as well, it also hinders the scientific progression of this body of work, and it likely further contributes to that substantial volume and variability in the literature. So based on that scoping review, we understand the scope of the instruments that are available to exist to measure the nurse-patient relationship. And really importantly, what this work shows is a dissonance between the rhetoric on the importance of the nurse-patient relationship and the rigour with which that relationship is actually conceptualised and measured. And in turn, the state of the literature makes it really difficult to determine the potential utility of each of these instruments as well. It is possible that some of the instruments we identified in the scoping review are sufficiently rigorous and robust to warrant their use. So the next thing we had to do was answer that question. Are any of these instruments any good? We know that there are some limitations in the literature, but if we had to pick an instrument to use, which would it be? And of course, that has direct implications for how we might document the nurse-patient relationship in nursing and patient records. So to answer this question, we built on the findings of the scoping review, and what we sought to do was to evaluate the quality of the existing instruments. So we did that by evaluating how the content or the items of each instrument were developed and then selected. And then we also evaluated the measurement or psychometric properties of the instruments as well. And these different elements were each rated as good, acceptable, or poor. And we also sought to identify whether any of the existing instruments would actually help to measure the relationship as it is conceptualised within the Fundamentals of Care framework. So to assess that, we mapped the items from each instrument to the framework's core relationship elements of trust, focus, anticipate, know, and evaluate. So that would help us to understand whether any of the existing instruments appropriately measure the relationship as conceptualised within the framework. So for this study, we could only include 27 of the 35 instruments, and this was because only 27 of them actually had a paper reporting on the measurement of psychometric properties of that instrument. So the findings further reinforced that patients and nurses were rarely involved in content development, selection, or refinement. And as I said before, if nurses and patients were involved, it was often minimal. So they were often asked simply to review the relevance or comprehensibility of items. In other words, they were simply asked, does this item make sense? And most of the instruments also exhibited poor measurement or psychometric properties as well. And as the scoping review also identified, often key detail was missing from these studies, and only one instrument actually had complete information on all quality indicators relating to psychometric properties. So based on that evaluation, we concluded that there doesn't appear to be a high quality instrument that currently exists measuring behavioural aspects of the nurse-patient relationship. In terms of the mapping, we identified and extracted 500 different items from each of the included instruments. And of those 500, most mapped to trust and also to know. So most of the content of existing instruments seem to focus primarily on nurses getting to know their patients and earning their trust. Interestingly, only one of the 500 items actually seemed to map to the element evaluate. And 17% of the items didn't clearly map to any of the core elements of the relationship. And many of those items addressed clinical care or maybe the physical care setting as well. But some items also seem to focus on the nurse and patient liking each other or the nurse and patient liking their job. So what our work to date has shown is that the nurse-patient relationship and how we measure it has been the focus of much research. But we don't necessarily seem to be much closer to solving the problem of how can we appropriately assess and of course document the relationship. So to do that we have to consider several factors, and these factors I will discuss in detail in part 3 of the presentation. And just before we do that, again, I have posed some questions for you that you can spend around 10 to 15 minutes discussing. And I'll see you back for part 3 of the presentation. Thanks.